In any event, you guys ready to learn about corns, bunions, and ingrown toenails? Okay. Well, actually, I'm going to talk about the foot and ankle, really more from I don't have anything against podiatry or anything like that, but just from a sports medicine perspective and some of these injuries that we're facing in the work comp population. So she went over my background. I'm actually originally from Denver. It was the Chicago Bears that initially brought me to Chicago and fell in love with the city. I did get a chance to go back and do a mini sports trauma fellowship in Aspen and help cover the 2005 X Games. So can you imagine any other occupational health hazard than what these folks are doing? So again, we're going to talk about foot and ankle. I'm going to share some anatomy. We're going to talk about some of the things we're doing through the arthroscope. Ankle sprains, probably one of the most common injuries that you guys have to deal with over and over again. Subtalar injuries. We'll talk about some tendon issues, tendinopathies, and some trauma. I also want to share with you some of the terminology in terms of bad players, because there are key diagnoses that kind of should elicit a red flag or some type of response that, you know, this could be a problem if we don't manage this right. So we're going to go over those as well. In terms of foot and ankle, it's very important. You know, we oftentimes ignore the foot and ankle because it's the foot and ankle. You know, it's not the knee, it's not the shoulder, it's not the elbow, it's not the spine, you know, the bigger, sexier joints. So we tease the foot and ankle. Any foot and ankle people? We tease the foot and ankle surgeons oftentimes and the podiatrists, but in reality, the foot and ankle is extremely important. And in sports medicine, we recognize this, and it all has to do with the kinetic chain. I mean, everything is from the ground, all the reaction forces from the ground up. So a lot of pathology that we see in the knee, in the lower leg, the knee, the hip, even the lumbar spine is actually originating from the foot and ankle. Bad biomechanics. A lot of this has to do with how the heel strikes the ground. There's certain mechanical property that takes place. The ligaments have to unlock. The calcaneus has to be in a certain position as you absorb energy. Okay, and then when you roll over onto your toes and push off, you lock certain joints in the foot to kind of manifest that energy that's been absorbed. And then that calcaneus goes into a certain position, you're able to push off. This is very specific mechanics, and if those are off because of an injury, it can lead to a lot of problems. So in terms of dealing with the anatomy, can you guys see this pointer? Okay. So the foot and ankle is a very complex joint. I mean, you have the end of the leg, which is the tibia, and the fibula, okay, on one side, and then you have the talus on the other side, which is right here. That's what makes the ankle joint. And then you have the subtalar joint as well, which involves the talus and the calcaneus and some of the tarsal bones. And then you have your main ligaments here that we'll get into later in terms of defining some of these injuries. Here you can see the two main ligaments on the outside of the knee here that are often implicated in an ankle injury, anterior talofibular ligament and the calcaneofibular ligament. These are oftentimes injured. Here on the medial side, you see this broad, expansive tendon. It's extremely strong. This is called the deltoid ligament. This is really the main stabilizer of the ankle joint. And so if somebody has a lot of medial-sided pain and injury there, we know this is going to be a little bit more significant injury. So in terms of the anatomy, one of the things that as a sports medicine surgeon that does a lot of arthroscopy, a huge part of our practice involves looking at joints through the scope. This allows us to get diagnoses, evaluate, really see the ankle in a different light. And so I'm going to go over kind of some of the patient information, patient videos that I often share with patients in terms of what this is. So this is an ankle scope. It's a lot smaller than the usual scope that we use. We're able to go in and see a lot of the anatomy. What's interesting is that typically we're using a lot smaller scope than we would for the shoulder or knee. What's good about it is that we can really define what's going on. We see the different parts of the ankle that I share with you, the tibiofibular talus. We can see how the ligaments move inside the joint, how the tendons come together and move the ankle joint. We could also identify the subtalar joint, which is a very complicated joint, again involving the talus and the calcaneus. We can see how these joints move. And like the hand and wrist, there's a lot of complicated anatomy in terms of the tendons coming down, the Achilles tendon, which you see right here, the nerves. We're all in a close proximity in the neurovascular structures, as you're seeing here. Another thing is a lot of times, and we'll get into this, the imaging that we employ, the X-ray, CT scan, and MRIs, do not show a lot of the pathology. And so you'll see people that have chronic ankle pain, and we don't know why. We don't have a clear explanation. So this gives us the ability to go inside the ankle joint with the scope and look for scar tissue, look for loose bodies, look for chondral injuries. All those type of things we see typically. Just like the shoulder, we use traction, okay, and able to open up the ankle joint, small little nicks, arthroscope. How we blow up the ankle is insufflating it with saline, as you see here. And the patients really like it. I mean, outside of having to make a large arthrotomy, it's a quick recovery. Very small puncture wounds, and we're able to document a lot of good information employing the arthroscope. One of the videos that I wanted to share this was actually a work comp case of a lady who had an ankle sprain about 2 years prior to her showing up in my clinic. And she had a diagnosis of ankle sprain and just continued to have a lot of pain and couldn't fully get back to work. And so ultimately we got I did a arthrogram MRI. And part of that was a diagnostic arthrogram MRI to see what was going on. And sure enough, she had a lot of scar tissue in her ankle, which you see I'm cleaning that out right now. She also had a loose body that we detected through the MRI. And so what you're going to see is I'm looking at the talus right there. That's the articular cartilage of the talus. Right underneath is the tibia. I'm going with the shaver now to clean up a lot of that scar tissue, that extra inflamed synovium. All of this is what generates pain, a pain response, keeps the ankle inflamed. But this is this large osseous loose body sitting right at the front of the ankle. And she'd been living with this for 2 years. Okay, so this is, again, part of the advantage of being able to put a scope in and actually take a look at this, and through these tiny small incisions actually take that out of the ankle. So this is actually a case I just did last week, so I have to let you know how she does on our next talk. And this is me pulling this loose body. I have the grasper there, and this is me pulling it out of her joint right there. So as you can see, I mean, these are real causes of pain. So moving on, ankle sprains, again, one of the most common injuries that we have to deal with. The initial inspection is what's critically important. You can learn a lot about an ankle sprain just by how the injured worker presents. If it's a significant injury, let's start with a mild ankle sprain. A mild ankle sprain may not have swelling, okay? A lot of point tenderness over these ligaments. Some difficulty, a sense of instability, mainly pain-related, but they may not have a lot of swelling. They should not have a lot of bruising or ecchymosis. A moderate ankle sprain, you're going to have more swelling. Okay, you may have a little bit of bruising. And a significant ankle sprain, you're going to have gross swelling. Those are those workers that had a bad ankle turn, and they present right away with an extremely swollen ankle. Then over the next day or two, they start to develop this bruising that you see right here, this purple and blue. This is letting you know that this is a significant injury. Why this is important is sometimes in our IME work, I like to see what the initial evaluator documented in terms of the injury. Because of the records state, no swelling or very, very minimal swelling, then that's an indicator of how severe or significant this ankle injury was. So that's an important key. So this is an example of what we would consider a grade 1 or type 1 ankle sprain. You can see some of the stretching of the ligaments there, but no real pain. There may not be a lot of swelling or bruising in a picture like this. You can see that right there. Now this would be considered more of a grade 2 or type 2 sprain. So again, this is your ATFL or anterior talar fibular ligament. You can see there's a partial tear. This ligament right here is the weakest. This is what's torn. It's the most commonly torn ligament of the ankle. And then you have your calcaneofibular ligament right here, the CFL. These two really form the lateral ankle complex. This is torn in a second incidence or rate compared to this one. If they're both torn, then you can have a pretty unstable ankle. As you see here, this would be considered a type 3 or grade 3 ankle sprain with complete rupture of the ligament. So this is just kind of going over the wording of what I just illustrated to you guys. We're looking for deformity, any type of edema, ecchymosis, bruising. This exam I'm demonstrating here in my hands clinically isn't as important as just understanding the injury and exactly what's injured. So with our clinical exam, we could pinpoint, is this a fracture possibility? Is it more bone pain, contusion? Is this a particular ligament? Okay, so knowing exactly where these ligaments insert. Is this a ATFL ligament versus a CFL ligament? Both. Is this a deltoid injury? During the initial presentation, a lot of times they're guarding, they're in a lot of pain. It's really hard to get a true sense of their stability. But the textbook example is the anterior drawer test. So you're trying to see how much anterior shift you're placing the talus underneath the tibia. With this particular exam, you're testing more the ATFL, and that's the most commonly injured ligament. Then you have your talar tilt, okay? Sometimes if you really want to assess this, you can inject the ankle joint. I'm not a huge fan of injecting joints with a numbing medication in the form of lidocaine or marcaine in young ankles without any real cartilage issues. But if you had to make this diagnosis based on an exam, this is a trick that you can do, injecting the ankle. This is kind of tricky, though, because there's a lot of people that have lax ligaments, and this can be a normal finding on the other side. So again, that's why these exams aren't as important. I think they're definitely used later when we're dealing with more chronic instability and trying to assess compared to the other side where they stand. X-ray findings are very important. So you can do stress x-rays. We have a live fluoroscopic x-ray machine, a mini C-arm, so we can take these x-rays live while we're actually stressing the joint. And there's certain parameters, degrees that make it abnormal, okay, compared to the other side. Here's 6 degrees of increased tilt. We know that that's abnormal. So this is clearly an unstable ankle joint, okay? When that's going to most likely require some type of surgical intervention. MRI. Okay, the MRI is going to be the diagnosis of choice in terms of dealing with some of these chronic ankle ligamentous instability issues. It's also a great modality for looking at other issues like loose bodies or chondral injuries, which I'll show you a little later. But this is just some of the anatomy looking at the ATFL, the anterior ligament, the posterior ligament. We can assess normal structures. We can assess pathologic structures. We can see if this is more of a chronic stretching of the ligament that started to swell and it's scarred now, so it just doesn't look normal, all the way to a complete rupture or complete absence of the ligament. part of this all comes down to giving us some sense of how significant the injury is. And that's what goes into all the different classifications and grading systems. As I mentioned, grade 1, 2, 3. Some people get very simple. And, you know, as surgeons, we want to know, is this stable or is it unstable? Okay. And that's how we like to address it. Most stable injuries will be treated non-operatively. The only time we treat a stable ankle injury operatively is the example I showed. The chronic pain, inflammation, possible loose body, possible cartilage damage, things of that nature. Unstable, now we have to assess, is this something functional or not? Okay, a lot of times if they have a subjective sense of instability, on exam it feels unstable, but they don't have any real x-ray findings of instability, meaning the Taylor tilt test isn't grossly abnormal. A lot of those we're going to, again, try to treat conservatively, non-operatively. But on exam and on x-ray, if I can, like that x-ray, show that pretty severe Taylor tilt, those are most likely going to require a surgical procedure to stabilize. And then at the end of this cascade of the force that's being generated to disrupt ligaments, okay? If that force is just off in terms of where it's entering the ankle joint and exiting, now you have ankle fracture, okay? And that's what it is. It's all a matter of where that ankle was positioned in time and space to what injury you're going to end up with, okay? If it's higher up, that force is going to cut right through the anterior talofibular ligament and exit. It needs to exit somewhere, okay? This is physics. Force, you know, it comes in and it has to exit. So a lot of times it'll choose to exit right through the fibula, and so you'll, can't find myself. So the most common fracture you'll see are these distal fibula fractures, okay? You may have a fracture in the back as the force that's generated wraps around the ankle. And then if it's significant enough, it'll reach all the way to the inside and fracture out through the medial malleolus. So when you hear that, those are those bimalleolar or trimalleolar fracture patterns, and that's letting you know this was a higher degree of force that caused that injury because the force had to wrap all the way around the ankle. How we fix these is this is probably one of the most consistent and standard ways as orthopedic surgeons we've treated any issue. A lag screw and a plate on the fibula and partially threaded cancellous screws to get a nice compression on the medial side. So this is very standard. Plate and screws on the lateral side, screws on the medial side. Again, what's important is understanding the anatomy, understanding, if you're the first responder, is this open, is it closed? If it's open, that's orthopedic emergency. Okay, we have to get that washed out. It's bone, high rate of infection. If it's closed, you're typically not going to be able to do surgery for at least a week or even 2 weeks sometimes because of the swelling. But you have to assess, do you need to put it back in place? I'm a football player, you guys. So I gotta share some football pictures with you. The personality, okay? This one has a bad personality, right? This isn't good. So this is a nice example showing how that force gets generated, wrapping around the anterior talofibular ligament, fracturing through the distal fibula, wrapping around to the posterior aspect, and then coming through and rupturing the medial side. And it's all having to do with the degree of supination that takes place at the ankle. Do you guys want to see that slide again? Ankle fracture. As we mentioned, again, one of the advantages of being able to look inside an ankle with the arthroscope is the cartilage injuries in ankle fractures and even high-degree sprains is common. It's more common than not, okay? If you're dealing with lateral ankle injury, 66%. If you're dealing with medial-sided, that deltoid ligament, again, that's the strongest ligament in the ankle, If that's injured, you pretty much can expect there's some cartilage injury that took place. Now, that doesn't mean it's going to lead to surgery, but what that means is we have to be aware and protect the ankle a little bit more, knowing that the cartilage is vulnerable. Okay, there's some degree of injury. One of the things that, as that video I showed, this was a lady that she presented to me 2 years after her initial injury. So we see these people with this chronic swelling, chronic pain. Sometimes it's a subjective sense of instability, but sometimes it has nothing to do with the ligaments. The ligaments have healed. It's the intra-articular pathology. We term this intra-articular pathology meniscus syndrome. Okay, so they have scar tissue that's impinging and causing pain. Okay, inflamed synovium. All these things are painful. We also can term it lateral gutter syndrome. You've heard those terms. So the gutter literally referring to the space right between the fibula and the talus, or the medial malleolus and the talus. So this is actually a picture showing some of that inflamed synovium that we go in and can remove all that and really open up the joint space. So how do we treat these? Pretty basic, and it's very similar with any sprain, no matter where you are in the body. We want to initially protect it. So ice, compression, try to get rid of the swelling as much as we can, anti-inflammatories. And we want to protect it initially. If it's a significant sprain, we want to protect it with a brace. If it's a grade 3, we may even consider a boot and non-weight bearing for at least 7 days. Or even 14 days if it's pretty significant. The key is early mobilization. Okay, if somebody's been treated in a splint for months, which I've seen some of those patients show up in our clinic and they've been in a cast for 6 weeks or been in a boot for 2 months and they haven't had any therapy or mobility, that's a detriment to the ankle joint. So that's something that we definitely we want to avoid. This brace is really only good for that initial injury, okay? So if you're seeing somebody treated with this 6 weeks out, it's not doing anything. This is a good pneumatic brace to help with that initial acute post-traumatic swelling. Outside of that, we're talking about real lace-up supportive braces that you see the athletes, the football players wearing, nice supportive ankle braces. Therapy is critical. This is probably one of the most critical things I can say about dealing with ankle sprains and even post-operative fractures. A lot of times it's neglected. We get an ankle sprain. We know that it's going to eventually heal and we're going to be able to do what we need to do. But we have this persistent pain and sometimes instability. Instability in the form of, we're walking up on a uneven, unlevel surface, or we hit a curb and our ankle turns, and we're realizing it's turning more and more. Okay, it's just not what it used to be. And the reason, we never really got that proprioception back. We never fully awakened the small ligaments and tendons that make up our foot and ankle joint. Again, you remember, this is very complex. A ton of these small little intrinsic ligaments and tendons that go to sleep after an injury, and you have to purposely wake them up. Okay. And another thing that's important is it has to be the right therapy, okay? And that's why I'm actually an advocate for the orthopedic surgeon or in particular the sports medicine surgeon being the first responder, because our natural goal is to get these injured workers back to work. And we understand how to do that versus bleeding the patient. Bleeding the injured worker, okay, for therapy, but not understanding the real biomechanics and how we're truly going to get this injured worker back to work. And for us, it's just like treating an athlete, okay? Our goal is to get this athlete back on the field as quick and safe as possible. So understanding what all this means, understanding that it's not simply a matter of keeping somebody casted for a long time or doing a whole lot of physical therapy that's not warranted or the right type of therapy. It's really understanding the science and getting the patients back. So now we've done the therapy. We're a ways out, and the patient is just not happy. Okay, they're complaining of that instability. They're complaining of they can't get back to work full duty because their job requires them to balance on one leg with a heavy load, and their ankle feels like it's giving out. And so the case that I did, and I'll show you, was similar to that. He had a bad foot and ankle injury. They initially got an MRI, which again, another reason why orthopedic surgeons should be the first responders. Half of the MRIs that I see, I wouldn't have ordered at that time. Okay, they're not indicated. There's no real reason to get an MRI after an ankle sprain initially. All it's going to do is show a lot of swelling, edema. It's not going to, even if it shows a ligament tear. Well, an ankle sprain is a ligament tear, right? So we know that. It's how we treat it. So they got an MRI right after the injury, showed a lot of subtalar edema, bone contusions, okay? So it looked very dramatic. So what did they do? They casted him. They casted him for 2 months. Didn't do well. They took him out. Had a lot of pain, stiffness. Came to me. We tried therapy. We got him going, but I could not get him back to work full duty. Okay, we got him back to where he was pretty functional, but he started to complain of instability. So eventually, I examined him. I was examining him the whole course, but my focus changed a little bit to this is more instability issue. And I did a stress radiograph, and sure enough, he opened a little bit more than I was comfortable with. So I did a MRI arthrogram, and sure enough, he had a complete tear of his anterior talofibular ligament. So that's, it's a long, drawn-out case. Maybe, I don't know if it would have been any different, but when we do see those patients, this is a nice, simple repair of this ligament. And the studies do show if you can get to the patient early enough and they have enough tissue, doing a primary repair is better than doing a lot of the fancy big ligament reconstructions. This is another modification where we actually take some of the extensor retinaculum and repair it as well. So this is this gentleman I'm referring to. We actually took him to the OR, did a small incision right over the ligament, which part of the ligament is, sometimes it's not a true ligament, it's a thickening of the capsule. Okay, so it's all part of the same capsular sheath. It's just a thick band that is what is identified as the ligament. So luckily for him, he had very robust tissue there. It just wasn't functioning properly. It was stretched out. So you can see I can get my instrument directly underneath this ligament. This is showing after I've incised the ligament. So now I'm looking directly into the joint. I can assess any cartilage damage and clean out what's going on. And then do a pants over vest type of suture technique where it's an imbrication. And it's a nice technique to really tighten up that lateral ligament structure. So this is a picture here. I don't know if you guys can see how these sutures are arranged, but it's a pants over vest where I'm actually pulling the tissue over the other layer and then tying it down. And then you can see here a nice, nice solid repair. As I mentioned, these do very well. And when you compare them to some of these more tendinous reconstructions, there's a million different ways to do these. You can use your own tendon, or you can use allograft. In my opinion, these work pretty good, but the reason that the studies show if you can get to them early enough and they have good tissue, primary repair works better, is because it's an anatomic repair, right? You're not affecting the insertion sites of these ligaments. When you're doing ligament reconstruction, as we know with ACL reconstruction, we've spent decades trying to replicate exactly where the ACL inserts. It's all about the biomechanics. So I think that's why the primary repairs do better. Ankle dislocation, again, that's a bad player. Anytime you hear that, treatment should be guarded. You want to make sure those injured workers are in capable hands. By definition, ankle dislocation, all the ligaments have ruptured, so that deltoid ligament's ruptured. There's a high incidence of chondral cartilage damage. So again, if it's not treated appropriately, this could be a problem down the road. We do want to cast these, But even with the ankle dislocation, look how long I'm casting it for, okay? Only for about 3 weeks, okay? Then I'm coming out, and we can start doing some weight bearing, with a boot, and start doing some light formal therapy. There's another dislocation that can occur too, and that's in the subtalar joint. These are rare and they're very dramatic. I actually had a high-level basketball player tear right through the subtalar joint, and this is what it looks like. Yeah, this is an orthopedic emergency. His vessels, nerves are all tented. His bone is getting ready to come out the skin. But amazingly, if you get to these soon enough, get them reduced, as long as they don't have a big fracture that's displaced, these patients actually do pretty well. And again, with the right amount of immobilization and casting, the right amount of therapy, we got him back, and he's playing over the rim. Like anything, we can find ways to reconstruct it if need be. So cartilage injuries, this is a passion of mine. Obviously, being a sports medicine doctor, we do a lot of cartilage preservation techniques. There's something about cartilage that we just have not been able to replicate. I mean, it's when you look at the structure, it's an amazing, at the microscopic level, it's such an amazing structure that anything we do to replace it is a salvage procedure. So you guys have to understand that. When there's a cartilage injury or cartilage loss, and we're doing any type of cartilage work, that's a salvage procedure, no matter how mild it may be. But cartilage is one of those things where once you lose it, we can't replace it. And the things we do, we try to get as close as we can, but it's again, just a very amazing structure. But this is an MRI that's showing a cartilage lesion. You can see the talus. We see these in some of these bad ankle injuries that just never resolved. This is what a complete unstable cartilage lesion may look like through the scope. Okay, so there's different techniques. This is showing a Oates type procedure. This is the lesion right here. We can do like we do in the knee. Okay, we can go into the knee and actually harvest a cylinder or a tube of bone and cartilage, and then use that to transplant back into the talus. One of the things that I'm doing though now that's new on the horizon is using juvenile cartilage. Okay, why juvenile cartilage is exciting is because the synovial, the chondrocytes, when you look at your own tissue, so even if we're using we're using autografts from the knee, we can look at how many live chondrocytes are in that area. When you compare that to juvenile cartilage, it's on a whole different magnitude. Juvenile cartilage has hundreds of thousands of these cells that's giving it a lot more potential to possibly grow into something that comes somewhat close to what you had naturally. Again, it's not replacing what you had. It's a salvage procedure. The other thing that's good about this is when you have cartilage injuries in the foot and ankle, we're talking about a very tight space. And a lot of times the cartilage injuries are in the mid portion of the talus, and it's hard to get to it. So we have to actually cut bone. We have to do osteotomies. Osteotomy of the medial lateral malleolus. You might have heard of these techniques. Well, with this technique, using the juvenile cartilage, I can do it through an arthroscopic assisted approach and make a small incision to fix this cartilage lesion. So this is showing a curette. I'm cleaning out the lesion, okay? What we do is we put a little fiber and glue at the base of the lesion. We pack these cells, okay, and then we cover it with the fiber and glue. What it looks like is this. So this is me actually, and this device is very expensive. It's true allograft tissue. It's not any more expensive than doing an Oates, but when you compare it to cartilage transplantation techniques in general, I mean, they're just expensive procedures. This little tube of cells is what makes it expensive. But anyway, this is me actually putting it into a pipette, and this is showing how you can then feed that pipette into the lesion and then cover it. And these are arthroscopic pictures showing what it looks like. So again, this is an arthroscopic picture showing that it's now covered, and then a close-up magnified picture showing the different morselized pieces of the juvenile cartilage. I'm just going to speed ahead now due to time, but Achilles, very common, one of the most common injured tendon in the foot and ankle. It's the main tendon that connects the calf to the heel. We have very mild tendinitis. We have peritendinitis. That's really just the tendons inflamed. We have tendinopathy. Okay, tendinopathy now implies that the tendon is developing some chronic structural changes. Okay, sometimes they're only evident under the microscope, where we see that it's starting to turn into scar tissue versus the normal tendon structure. And then there's gross macroscopic changes, where now you have big bulbous type of tendons. You feel people, they have a lot of deformities in the back of their leg in terms of over the tendon. Why this is a problem for us, one of the reasons is that, again, the Achilles is a bad player. If somebody has and develops bad Achilles tendinitis, it becomes a nuisance. It's very difficult to treat, to cure, I should say. Reason is the blood supply. Okay, the vast majority of people that's having tendinitis, it's in that area of what we call a watershed, where the tendon is just not getting adequate blood supply. And so it just becomes an issue. In sports, we see it with a lot of overuse. Sometimes there's alignment issues or other biomechanical issues that put people at increased risk, like tightness of the calves. So we do a lot of therapy to try to stretch out the calves. People being flat-footed or having too much of an arch, all those things can play into it. So we have to look at all that. Again, this is just going over the different stages of bad Achilles. This is the MRI showing what a normal Achilles signal looks like. So you guys see this normal oval structure right there. This is a bulbous, I'm going to show you what this looks like in real life. A bulbous, just scarred tissue that loses its mechanical properties. So you can see how it just gets swollen, and it's a lot of scar tissue there. In terms of treatment, a lot of times it's rest. Okay, we're talking about basic Achilles tendinitis, decreasing the load. Sometimes how we do that is putting people in a heel lift. Sometimes all they need is a little heel lift to take the pressure off of the Achilles. Eccentric stretching, so physical therapy, employing ultrasound therapy, E-stim, all of that, massage, deep tissue, all of that is designed to try to stimulate blood flow. It's all, you can name it what you want. All these different techniques are designed to try to increase blood flow. One of the things that we are also employing are nitroglycerin patches, believe it or not. The reason, it increases blood flow to that area. I'm weary of steroid injections. There's actually literature that has established some degree of safety if it's done very judiciously. The problem is it's hard to ensure you're injecting steroid just in the tissues that surround the tendon. If you inject the actual tendon with the steroid, you're going to make that tendon weaker and lead to an increased risk of rupture. So I don't put steroids around any of these big tendons like this. It's not worth it. And I've seen cases where people have had chronic tendinitis. They've had multiple steroid injections. They end up tearing. And at the end of the day, it's not the answer. It's not the solution to this problem. There's non-operative and operative treatment. I'll speed ahead. In terms of non-operative treatment, we're finding that with the right techniques in terms of casting and splinting with a degree of plantar flexion, we are getting people back to a very good to excellent status, even full, complete Achilles ruptures. So even somebody that is a high-functioning worker, their duty is heavy. Okay, their job description, they're a heavy-duty. Even that person could do fine, actually just as well now compared to the surgical. We used to always operate on athletes and high-demand individuals because of the re-tear. It was a lot greater re-tear rate in people treated non-operatively, okay? So if somebody's putting a lot of force on their Achilles, they wanted that strong repair. But we're starting to see some of this new, and you guys can read through some of the wording here on your leisure. Some of the newer literature is actually showing these patient demographics actually do about the same, again, if they're treated the right way. So this is a personal decision. It's not a clear-cut answer who gets surgery, who doesn't from a Achilles rupture. Bad tendinitis or tendinosis that just we cannot heal, we cannot get to calm down. A lot of times those will require surgery just to cut out all the bad tendon and do a repair. This is an example of one of the worst Achilles situations you can have. This was a chronic rupture. It never healed, developed a lot of bad scar tissue. So this is showing normal tissue here, normal tissue here. Well, that's a huge gap. This tendon in the middle is the plantaris tendon that stayed intact. So again, this is showing all this is worthless. It's just scar tissue. If you have a 5-centimeter gap, you can't close that. There's no way you can close it on its own. So we have to start talking about reconstruction. So now I've cut out all that bad tendon, and you can see now this is muscle. So I'm all the way up to the calf. Calf, and then the stump of the Achilles down here. Huge gap. What are we going to do about that? Well, that's when we do VY plasties. We start getting into a little bit creative reconstruction. And so this is me shifting that tendon. I'm doing a collagen graft to give it more support. So that's what I'm doing, a collagen weave graft to give it more support here. And then I'm employing my whip stitches, a heavy-duty suture technique. And believe it or not, we were able to bridge that gap. Now, this person literally was in plantar flexion like this for a long time, but they eventually actually got to neutral and even got past was able to dorsiflex and did pretty well. Remember I showed you that bulbous tendon, that big bulbous tendon? So this is the MRI. This is what it actually looks like, okay? I mean, it's all of this is scar tissue. It doesn't have any mechanical strength to it. So I treat this a little different. This is somebody who wants strength, okay? They need power in what they do in terms of lifting off. So there's a technique where we can actually harvest the flexor hallucis longus. This is a very robust tendon, so that's what you see here. Here's the plantaris tendon. I'm going to use that as well. Here's good Achilles tendon. What's different about this one and the one before is that proximally there was enough tendon where I can get good sutures in, so I didn't have to do a VY plasty. But essentially, I did a reconstruction with the FHL where I'm putting that directly at the base of the heel, right in front of the normal Achilles. This is a screw, and here's that tendon. So now we have to train that tendon to become an Achilles tendon. Okay, we have to train it. That's the neuromuscular training, but it's going to have the strength that this patient's going to require. And then after that, we did the repair and then was able to augment it with the plantaris graft, spreading it out and covering the whole repair. And as ugly as it looked, at the end of that, this was the incision. Looked pretty good. I'll just end with Jones fractures, another bad player. What's amazing about this is Jones fracture is literally a couple of millimeters away from the base of the fifth metatarsal, and it's treated completely different. So if you have a base of the fifth metatarsal fracture, which is right here, these workers can do pretty good. They can go into a post-op shoe, immediately bear weight. It's a heavily vascularized area. It's going to heal. These patients typically do well. But if the fracture is just a little bit distal, we're again in a watershed area. Okay, the blood is just not getting where it's supposed to. You can see right here You have blood coming into the base and blood coming through the shaft. And these fractures have, some studies show up to 50% non-union, okay? In the NBA, if you're a professional basketball player and you get this fracture, even if it's non-displaced, okay? If you get this fracture, a lot of times they're putting a screw in it right away. They're putting a screw in it. They don't want to waste time seeing if they're going to be in that 50% that don't heal. So this is, again, a picture showing the watershed area, compression screw, and these are pictures showing how we actually do it. Very tiny incision, and we're able to get it done pretty well. So thanks for your attention. I know that was a lot, foot and ankle. Any questions?